Hello everyone and welcome to today's webinar, Preventing Occupational Injuries from Ampoule Cuts. Your presenter today is Dr. Michael Sinnott, Senior Clinician and Innovator with ClickSmart. Michael is a Senior Clinician and Innovator with strong management, research and education skills. Michael was involved in clinical medicine for over 35 years before retiring in 2018. The majority of that time was spent in the emergency department. In the field of research, Michael promotes an evidence-based approach to emergency medicine, research and practice, and the development of a culture which generates and supports research findings. Michael was a driving force in designing the Queensland Emergency Medicine Research Foundation. Michael has contributed to over 40 publications and is a world leader in research regarding staff safety in healthcare. His expertise led him to become involved in the development of safety guidelines and legislation in the United States and safety standards here in Australia. In the commercial space, Michael is the co-founder of ClickSmart Proprietary Limited and SmartStream Proprietary Limited, who innovate and commercialise safety medical devices. Thank you so much for joining us today, Michael, and welcome to the microphone.
Good afternoon, everyone. I would like to start this talk, Preventing Occupational Injuries from Ampoule Cuts, by thanking Sue Walker, Jeffrey, and the team at NCPDI for the invitation to talk to you about this important topic. Today, we will achieve the listed learning objectives by utilising a mixture of updates of the theory, a review of some clinically relevant case studies, and challenging thought experiments. We will start by looking at the incidence of ampoule injuries and their consequences to staff, patients, and healthcare facilities. It is important to note that patients and the hospital itself both suffer when you are injured. Next, we will review the regulations in Australia relevant to ampoule and sharps injury prevention. Slowly but surely, healthcare is starting to realise that these rules apply to us as well as everyone else. We will then explore ampoule injury prevention strategies using the hierarchy of controls and apply them to clinical practice. Again, we will see that healthcare is relatively late to this party. Finally, we will analyse how safety is managed at each level of responsibility, the three levels being national, organisational, and individual. Our aim here is to give you an important overview of how your safety can be improved. We will also demonstrate what you, as an individual, can do to be effective in promoting changes to create a safer workplace. Let's begin with a thought experiment. How many colleagues of yours see an ampoule cut or injury as a rite of passage? This exercise is designed to establish our preconceived or subconscious assumptions and beliefs. If some of us do see ampoule cuts as just part of the job, or even as a rite of passage, this is a big problem. It means that if we accept this normalisation of deviance, we stop looking at ways to fix the problem and to stop our friends and colleagues getting cut in the future. My follow-up questions to the audience, particularly those who have answered yes, are: is that okay? Is it acceptable in 2021 to feel that way, to feel that an ampoule cut is okay, just part of the job? Was it ever acceptable? Let's look at uncovering the problems of ampoule injuries. Ampoule cuts may seem like just a hindrance, but they can be very serious, and it's our strongly held belief that no injury should be considered okay, just like no harm to a patient should be considered okay. Let's look at the sharps injury data in more detail. Of the 18,000 sharps injuries occurring annually in Australia, most of the reported ones are caused by needles or scalpels. These are the injuries that nurses are taught to report. However, as we have seen before, this figure is likely to be a gross underestimate, as only 50% of sharps injuries are reported in Australia. This unreported rate of 50% is likely to be much higher for ampule cuts, as they are often not thought of as real sharps injury by staff, and they may not be specified as a reportable injury in one's local policies or procedures. As a result, ampule cuts often go unnoticed. Despite ampule cuts and injuries often being ignored, every time I'm in a room with nurses, almost 100% of them have either had an ampule cut themselves or know someone who has. They are the most common form of sharps injuries to nurses. In fact, 1 in 3 nurses report ampule cuts to their hands, and 30% of all sharps injuries occurring to nurses are caused by broken ampules. In fact, probably just over 10 years ago, I was in the Australian Embassy in Tehran, Iran, and while I was waiting for my appointment, I was speaking to the local senior administrative officer. When she heard about our products, she told me that she too had had an ampule cut in her previous life as an assistant in nursing. Small world, isn't it? This is an international problem. As you would expect, anaesthetists also commonly suffer ampule cuts. Over 50% of all sharps injuries experienced by anaesthetists are a result of ampule cuts. In one study of 97 anaesthetic sessions, it was observed that the incidence of hand lacerations secondary to opening glass ampules was 6% of all cases, and that the prevalence of visible old hand lacerations was 26%. There are basically 2 types of ampule injuries: a simple, uncomplicated cut, which makes up the majority, and ampule injuries that cause deep cuts to the skin and/or damage to digital nerves, arteries, and/or tendons. These serious injuries often require urgent microsurgery and up to 3 months of intensive rehabilitation following the repair. From personal experience, I always feel a bit of trepidation when I go to open an ampule. Before preparing for today's talk, I had never really contemplated this question. Was I fearing a simple cut or one of the more serious ones? Even the simple cuts hurt and bleed and could interrupt the care I'm about to provide to a patient. So if you similarly feel apprehension before you open an ampule, ask yourself, what are you worried about happening? Are you worried about a simple cut or a more severe one? Both are important and both need to be avoided. Let's look at the consequences of ampule injuries. Ampule cuts and injuries, like all injuries to staff, have consequences to the affected staff member, their family and their colleagues, to the patients and to the employing hospital or healthcare facility. That's right, your injury can and does have consequences for the facility and even the patient. Just because we don't talk about it doesn't mean this is not happening. Let's look at some of these consequences of the uncomplicated cuts. You bleed, it hurts, you may or may not swear, you stop doing what you're doing and get it sorted. Clean up the blood and cover the cut with a Band-Aid, or maybe you need to go to ED to get reviewed to see if it's more severe. If it is, you may need a suture and/or a tetanus shot. Then you go back to work, unless of course you work in one of those areas which won't allow you to work with an open wound. If you are exposed to infected blood with broken rather than intact skin, you are at increased risk of being infected with a bloodborne pathogen. The psychological sequelae include anxiety and distress that may impact self-confidence and even one's ability to perform everyday work tasks. There is also the risk of a bit of anxiety and apprehension the next time you open an ampule. The patient you are looking after almost certainly suffers a bit of time delay in receiving your care, and is at increased risk of a medication error. The risk to the patient is not much of a problem at an individual one-on-one level, but there are so many of these minor cuts that statistically, every now and then, one of these delays is significant enough to lead to patient harm. Every now and then, the hospitals will complain about the expensive medication that has been wasted. But the much bigger problem for a hospital is a drop in staff morale and increased turnover. This has serious consequences for staffing levels, important for both staff and patient safety. All staff injuries impact a hospital's workers' compensation premium calculations and can even result in a lawsuit. This case study from the UK is an example of a more serious injury. The anaesthetist was unlucky enough to have the broken ampule cause a relatively deep 2-centimetre laceration to his hand, but lucky enough that it did not damage a digital nerve, artery or tendon. The wound needed suturing and the patient, in this case the staff member, was off work for 7 days. Did that have a flow-on effect on patient care as well? Now let's come back from the UK and let me share a local story with you. A few years ago, I was contacted by an anaesthetist from a North Queensland hospital. This doctor had severed one of her flexor tendons when an ampule she was opening shattered in her hand. Her injury did require microsurgery under a general anaesthetic and 8 weeks of rehab. This is what she said to me when I spoke to her on the phone. "I feel stupid. Even 10-year-olds can work this out." This is an example of the imposter syndrome that staff injuries can lead to. So now that we understand that ampule cuts and injuries are a problem, let's review how they fit within your facility's regulatory obligations. Workplace health and safety regulations. Remember I said in the introduction that healthcare is slowly starting to realise that some of the safety laws in place apply to them as well as everyone else in Australia. This may sound a bit cynical, but the fact that we still have so many sharps injuries affecting healthcare staff suggests that my observations are true, at least in part. Let's go back to workplace health and safety legislation. It is a state-based system, but in around 2011, the federal government put in place laws to harmonise occupational health and safety laws across Australia. So even though this reference is from Queensland, the principles should be very similar no matter which state you're working in. They basically say that the employer needs to eliminate or minimise injury risk as far as practically reasonable. They recommend implementing risk controls as per the hierarchy of controls, which we will go into in detail shortly. They also require more serious injuries to be reported. So if your requests for a safer work environment are being ignored, maybe you or your union could talk to your safety advisor and point out this relevant legislation. The highly prestigious and influential National Health and Medical Research Council publishes the Australian Guidelines for the Prevention and Control of Infection in Healthcare. These guidelines also identify glass ampules as a sharps risk. They point out that the healthcare facility should have a sharps safety program in place, and they also reference the use of the hierarchy of controls as an effective way to prevent infection and protect staff. Let's pause for a moment while you ask yourself, what prevention strategies are in place in my facility to prevent ampule injuries? For the lucky few that have some strategies, I'd love to hear what they are and how effective they are, and I'm sure your colleagues would appreciate learning that as well. We are now going to go through the hierarchy of controls, which, as we have just seen, have been identified by the NH and MRC as an effective way to prevent injuries. Systematic implementation within facilities enables a greater uptake of prevention strategies. The hierarchy of controls dates back to 1950 when they were developed by the National Safety Council in America. They took an upside-down approach to the behaviour-based safety programs. The behaviour-based safety programs ignored hazards and risks and focused on critical workers' behaviours. The old way of dealing with staff safety relied heavily on elaborate mechanisms to check, inspect, observe, coach, reward, and even discipline workers. Does this ring a bell? Over the last 70 years, the hierarchy of controls have been standardized across most industries to reduce risk in a system-wide manner. Healthcare is finally reviewing and adopting this proven approach. Using the hierarchy of controls to manage occupational risks is mandated in regulations across Australia and throughout most of the world. They describe 5 levels: elimination, substitution, engineering controls, administrative controls, and personal protective equipment. I'm going to explain how these different levels relate to your workplace. I will use examples of how to prevent sharps injuries, in particular ampule cuts, to make my explanation even more practical. As you can see from the diagram on the right-hand side of this slide, sometimes the 5 levels can be combined into a smaller number. Elimination is obviously the best way of reducing injuries when it is a possibility. Examples would include giving oral medications when possible. Changing from IV or IM injections to oral or transdermal preparations also reduces the risk of needle sticks. Similar to elimination, substitution is an excellent way of reducing injuries. Examples would include replacing glass ampules with plastic ampules when that is a possibility. However, some drugs must be delivered in glass ampules because the drug reacts with the plastic ampule, and this changes the drug's pharmacokinetics. Now, when glass ampules need to be used, the best strategy for reducing the risk of injury is the use of engineering controls. Engineering controls cover devices specifically designed to protect the user from injury. You may come across examples of staff using gauze squares, paper towels, alcohol wipes, or even part of their uniforms to open glass ampules. This is done in a bid to protect themselves from injury, but surprise, surprise, none of these workarounds are designed for this task, and as such, they are not deemed to be engineering controls and should not be used to open glass ampules. Examples of real engineering controls include specifically designed reusable or single-use ampule openers. The reusable ampule openers have the advantage of being more economical, and it's worth noting that staff often forget that alcohol wipes, gauze squares, or syringe barrels are not free and also incur a cost to the hospital. The Centre for Disease Control in America estimate that up to nearly 90% of sharps injuries can be prevented by using safety devices. At the next level of the hierarchy of controls are administrative controls. And I must admit that I had previously thought that administrative controls were a bit soft, but that was because I didn't really understand their purpose or their position in the hierarchy of controls. They are essentially there to ensure that staff actually enact the hierarchy of control solutions that were agreed upon. They include writing policies, including an exposure control plan, and ensuring staff are adequately trained in safe work practices and in the use of engineering controls selected. When implementing a program to prevent ampule injuries, it is important to ensure that the basic principles of opening ampules is taught to all new staff. An ampule can either be scored circumferentially, in which case the ampule can be opened from any side. This type of ampule scoring is usually indicated by a circumferential white line around the neck of the ampule. The majority of ampules, however, are only scored on one side, and in this case, the scoring is indicated by a blue dot on the conical tip or the head of the ampule above the scoring. In this case, it is essential to open the ampule by holding the ampule with the dot facing away and then applying the force to the back of the dot. This is where the glass ampule is weakest and is easiest to open. Regardless of where the scoring is located, the ampule should be opened in the direction away from the user and the faces of nearby staff. It is also important to ensure that nurses are trained in using the selected ampule opener, and if it's a reusable device, they need to be trained on how to clean the ampule opener. It's also important to ensure that sharps policies include glass ampules. The ampule openers either need to be carried by staff or fixed in a place in high usage areas, such as medication rooms and pharmacies, or better still, they should be in both. Let's go to the last level in the hierarchy of controls. Personal protective equipment is probably the most universally identified way of keeping staff safe, but it sits at the bottom of the upside-down pyramid for a reason. It is the least effective way of protecting staff from injuries. PPE is almost the option of last resort or the last line of defense. The first 4 levels need to be given greater significance and need to be implemented in conjunction with PPE, not replaced by PPE. Examples of PPE for ampule injury prevention include wearing gloves and protective footwear in case the ampule is dropped on the floor. I would like to re-emphasize that your safety is important. Injuries suffered by you have repercussions on your family, your colleagues, your patients, and your hospital. This is a very informative case study from a lab in the US. And even though they are from a slightly different workplace, the principles of what they did are very relevant to us. This laboratory noted that their staff had suffered several ampule injuries. So as per their facility's workplace health and safety policy, they undertook an investigation into what corrective action and preventative action needed to be undertaken. CAPA, corrective action and preventative action, is a term from industry. And again, we can see that healthcare has a lot to learn from other industries, especially when it comes to staff safety. Back to the US lab. They first looked up ways to eliminate the risk and then at ways to substitute the risk of ampule cuts. When they realized this was not possible, they went back to Google and looked for engineering controls. They found and tested 6 available ampule openers. The staff took part in the evaluation process and eventually they picked the ampule opener designed by an Australian nurse. Next, they implemented administrative controls, including safety videos and safety alerts. They also implemented hands-on training. Next, when it came to PPE, they recommended wearing gloves. This process was a successful approach to the problem and was presented as a poster at their professional body's annual conference. These principles and practices used routinely by other industries have not yet been fully adopted in healthcare, but they need to be. Let's pause again for a minute while you ask yourself, what do you think is the biggest barrier to a systematic implementation of prevention strategies in your facility? I'd like to follow that up with another quick question. Can you do anything about it yourself? Let's examine the answer to the last question. What part do you play in keeping your working environment safe? Now, to solve the identified problems, we need action at 3 levels of responsibility. At the national level, we must acknowledge the problem and establish the guidelines, regulations, and even legislation to address the problem. In this case, ampule injuries would be covered by an overarching sharps injury prevention guideline and/or legislation. Next, at the organisational level, we must fund the implementation of these strategies and measure both the change in practice and the results of this practice change. And last but not least, at the individual clinician level, we must both enact the solutions and feedback suggestions to improve on the solutions. James Reason's Swiss cheese model, which you may have heard of, was used to explain the consequences of systems failures on patient safety. Like the Swiss cheese model, all 3 levels indicated here have to be enacted at the same time to avoid preventable injury and error. Let's look at these levels in more detail. At the national level, we need to mandate sharp safety, including ampule safety, through legislation, regulations, and guidelines. This would include sharp safety practices and audits of the use of safety engineered devices in hospital accreditation processes. At the national level, there should also be investment in research, both sharps injury reporting data software and prevention strategies. Plus, we need to establish programs to support the uptake of new innovations. At the organisational level, we need to implement the hierarchy of controls to prevent all sharps injuries, including ampule injuries. In this case, the focus would be on safety engineered devices and administrative controls such as training on policies and devices. At the organisational level, we also need to create systems for analysing ampule injury risk, reporting hazards and injuries, and then performing root cause analysis after injuries occur, and then following that up with the timely implementation of corrective actions and prevention actions. And last but not least, reviewing innovations and suggestions from both inside and outside healthcare. As we said before, last but not least, at the level of the individual, we need to deploy sharps safety practices as determined by the review of the hierarchy of controls. That is, use the appropriate device for the situation and use it as directed. This has been dictated by the NHMRC Commission. At the level of the individual, we need to participate in evaluation of safety engineered devices, in this case, ampule openers, like the US lab did. We need to report ampule injuries and take part in investigations and activities. We need to engage in regular sharps training and mandate this for all new staff. We also need to speak up if we have an idea or an innovation which can improve sharp safety in our facility. Let's pause for one last thought experiment. How can you proactively prevent occupational injuries and make healthcare safer for staff? Please share your answers with your colleagues and the powers to be where you work. When enough clinicians like yourself make enough noise, things actually do change. Let's finish with one individual's inspiring actions, which we can all be proud of. Glenn Riverstone and the invention of Snap-it. Glenn was working as a nurse in the emergency department of the Rockhampton Base Hospital when he cut himself once too often with a glass ampule. Long story short, he went on to invent and patent what is now known as the reusable Snap-it ampule opener. Glenn's invention won the People's Choice Award on the prestigious ABC New Inventors Show in 2007. His Snap-it is currently keeping staff safe from ampule cuts in over 30 countries. Glenn's invention was the one selected by the US lab that we discussed above. I would like to thank my co-authors, Dr. Chimindika Konora, who has a PhD in biotechnology, and Maren Monteith, who has a degree in communication. I'm sure you would agree with me that that's a pretty good combination of skills and experience for this talk. Please see my email address, and I invite you to write to us with your feedback, questions, and other ideas on how we can make the future safer for ourselves and our patients. Thank you for your time.